All right. Thank you, everybody, for spending your evening with us. And thank you especially to the organizers for the invitation to speak tonight on pancreatic cancer screening of high-risk individuals. And special thanks to my colleague, Dr. Bahari, for really setting the stage so nicely for us tonight. So our objectives for this evening for my talk are to define individuals who are at increased risk of developing pancreatic ductal adenocarcinoma and describe an appropriate surveillance strategy for high-risk individuals. Now, Dr. Bahari set the stage for some of this, but these are data that come out of Johns Hopkins that are now over 15 years old, where we first started to realize that pancreatic cancer does tend to cluster more in certain families than others. And what they did here was compare the general population risk of pancreatic cancer, which at the time was about 9 per 100,000, and compare the risk when you had one affected first-degree relative, and a first-degree relative is a mother, father, sister, brother, or child, 2 first-degree relatives, or 3 or more first-degree relatives, compared with the general population risk. And what we found is that when the standardized incidence, when the one first-degree relative is affected by pancreatic cancer, the standardized incidence ratio for developing pancreatic cancer is elevated, but that confidence interval crosses 1. So individuals who have one first-degree relative with pancreatic cancer are not felt to be at marked increased risk of pancreatic cancer, but you can see that the confidence interval here is wide, and we'll get to some of that later on. However, when there are 2 or more first-degree relatives who have been affected by pancreatic cancer, the risk increases significantly. And so these are individuals who are at marked increased risk of pancreatic cancer. We call families that have 2 affected first-degree relatives of each other familial pancreatic cancer kindreds, and you'll hear a little bit more about FPC kindreds as we go on in the talk. Dr. Bahari also mentioned some of the inherited syndromes that predispose to pancreatic cancer, so I'll move through this slide pretty quickly, but we'll touch base a little bit on the evidence for BRCA1, BRCA2, as well as PALB2 and their risk of pancreatic cancer, ATM mutations, which by allelic loss causes ataxia and telangiectasia, but having one mutation in ATM causes breast cancer and pancreatic cancer. Familial atypical multiple melanoma has a markedly elevated risk of pancreatic cancer, as well as dysplastic nevi and melanomas. Peutz-Jeghers syndrome, Lynch syndrome, we've discussed already. We've discussed hereditary pancreatitis in previous talks. And familial polyposis, which is caused by mutations in the APC gene, is also described to be at increased risk of pancreatic cancer. So over a decade ago, we looked at the prevalence of BRCA mutations in an Ashkenazi Jewish cohort who had undergone surgical resections in New York City. And the reason we looked at an Ashkenazi Jewish cohort is because there are 3 founder mutations in BRCA1 and BRCA2 that can be easily discovered by simple Sanger sequencing. We looked at an Ashkenazi Jewish cohort who had undergone surgery for both pancreatic cancer as well as IPMN. And what you can see is that about 20% or so of the patients actually were found to have mutations in BRCA1 or BRCA2. And we actually found mutations in both BRCA1 as well as BRCA2. And I bring this up because there is some controversy about the association between pancreatic cancer and BRCA1 mutations. Since that time, our abilities to perform genomic sequencing has really markedly progressed with the advent of high throughput sequencing, and multiple groups have evaluated germline mutations in pancreatic cancer. These are 5 of several studies that have evaluated germline mutations in all comers with pancreatic cancer. And I put this slide up here not really to focus on the alphabet soup that's over on the left-hand side, but if you focus on the 3rd column, which is basically the prevalence of germline mutations in an unselected pancreatic cancer population, you can see that the later studies have about an 8 to nearly 10% detection rate for pathologic or likely pathologic germline variants. And what's interesting is if you look at this study from Pittsburgh, which included almost 300 individuals, And we looked at whether or not individuals met criteria for germline testing. Less than half of the individuals actually met criteria for germline testing. And furthermore, if we enrich the population for those who have affected first degree or second degree relatives, or who have a family history of pancreatic cancer, we find an increased detection rate for pathologic germline variants in patients who have pancreatic cancer. Beth Dudley and the Pittsburgh group have also looked at germline mutations in pancreatic cancer patients who had another relevant cancer. So for those who have been affected by pancreatic cancer and had another hereditary breast and ovarian cancer or Lynch-related cancer who underwent germline testing, 18% of individuals were found to have a mutation in a pancreatic cancer susceptibility gene. And if prostate cancer, which is a common malignancy, was excluded, the mutation prevalence increased to 23%. And the mutations that were found were similar to those described in other studies, including ATM, the BRCA mutation, CDKN2A, and the Lynch syndrome genes. And importantly, in this study, about a quarter of mutation carriers did not meet NCCN criteria at that time for hereditary breast, ovarian cancer, or Lynch syndrome testing guidelines based on their, even though they had either personal or family history of another cancer. The Mayo Clinic, in addition to performing germline analysis on their over 3,000 cases, also performed germline analysis of many controls. And so they were able to calculate an odds ratio or risk, essentially, of pancreatic cancer development for those individuals who had these genes that you see on the left side. And what you can see is that the germline mutations in the genes that we've described previously are all associated with markedly increased risk of developing pancreatic cancer. PALB2 is there on the bottom because even though the odds ratio was significantly increased, the authors of the paper did not feel that this increase warranted additional surveillance for pancreatic cancer. Now, what can we do for those who are asymptomatic, meaning that they don't have a diagnosis of pancreatic cancer? This is, again, work that we performed some while ago, where we categorized individuals into average risk, moderate risk, and high risk. And this is a somewhat outdated classification, but essentially think of those who are at high risk are those who carry germline mutations with a family history of pancreatic cancer, and those who are at average risk are those with one affected first-degree relative, which, if you'll remember from a previous slide, does not significantly increase risk. And so if you apply germline testing to a series of asymptomatic individuals, you can both change their risk stratification for pancreatic cancer, and you can also then perform surveillance for pancreatic cancer. And the overall diagnostic yield for those who are at high risk of pancreatic cancer in a multi-organ system surveillance fashion is around 33%. So when we performed surveillance for pancreatic cancer and for other associated cancers, for BRCA1 mutation carriers, we found pancreatic cancers. But it's important to consult your multidisciplinary colleagues because we also found ovarian cancer at prophylactic hysterectomy and oophorectomy. We found similar findings in BRCA2 mutation carriers, including a resectable pancreatic cancer. But you'll also see at the bottom here, we found multiple findings that are of really indeterminate significance. So we find mildly dilated pancreatic ducts, and oftentimes we find IPMNs or small cystic lesions in the pancreas, which warrant further surveillance, but their long-term significance is really uncertain in this population. How does this compare to what others have found? These are data from, again, the Hopkins group and the CAPS consortium, where they performed essentially simultaneous imaging in a blinded fashion for high-risk individuals with CT, MRI, as well as endoscopic ultrasound. And what you can see here is that in terms of any lesions that are detected, MRI and endoscopic ultrasound demonstrate findings in a third or so of individuals. Cystic lesions were found by both MRI and EUS, and they're found more often by these modalities than they are by CT scan. However, the combination of CT with endoscopic ultrasound missed about 7% of cysts that were actually seen on MRI. And the combination of CT plus MRI missed about 22% of the lesions that were seen on endoscopic ultrasound. The 3 solid lesions were actually all neuroendocrine tumors, and there are also 4 dilated main pancreatic ducts. And this led to the recommendation that for surveillance of high-risk individuals, CT is actually not favored, and MRI or endoscopic ultrasound are options for surveillance. How does this compare to what other groups have found? This is a study that comes out of Europe. It was another interesting study comparing MRI and endoscopic ultrasound in their high-risk individuals. What's interesting here is that 2 solid lesions were detected by endoscopic ultrasound only, and the detection of cystic lesions in the pancreas seemed to be superior by MRI. This has led multiple people to conclude different things. One is that, endoscopic ultrasound may be superior for detection of solid lesions in high-risk individuals. And really, when I counsel my patients, what do we really care about? We care about detecting early pancreatic cancers. But MRI might be complementary in its ability to have better detection of cystic lesions. All right. What about age of onset? Young age of onset is really one of the characteristic traits of hereditary cancers. And so this is a study that was also published about 15 years ago, where the authors compared the age of onset of the pancreatic cancer when the patients had a family history of breast cancer, ovarian cancer, colorectal cancer, melanoma, pancreatic cancer, or any other cancer. And what they found was that when there's a family history of breast cancer, the average age of pancreatic cancer onset was around 65, which is about 3 years or so younger than the age of onset when patients did not have a family history of breast cancer. And similar trends held true for when there's a family history of ovarian cancer, colon cancer, and melanoma. And if you'll recall our previous discussions, these are all the cancers that are associated with some of the hereditary syndromes that we see associated with pancreatic cancer. Interestingly, when there was a family history of pancreatic cancer, the age of onset of the pancreatic cancer was not markedly changed, nor was it changed when there was a family history of any other cancer. So it does seem that the age of onset perhaps is slightly younger when there's a family history of a cancer that could be associated with a hereditary syndrome. But the other thing to notice here is that the age of onset still remains, by and large, in sort of the 60s. And so pancreatic cancer, even when it is in the hereditary setting, does tend to be a disease of individuals who are over the age of 50 or 60. These are other data that support a later age of onset, even in the hereditary syndrome. So the top panel, panel A and B here, are pancreatic cancer mortality in panel A and all-cause mortality in panel B. For those who have 1 or 2 first-degree relatives who have been affected by pancreatic cancer. And panel C and panel D is pancreatic cancer mortality, and then in D, all-cause mortality for those who have 3 or more family members who are affected by pancreatic cancer. And what you can see here is that in panels A and C, the uptick really starts to happen after around the age of 50. So risk really does, in the hereditary setting, seem to increase with age. And European groups have also looked at this in some of their surveillance findings. And so this is also a European study published in Gut in 2016, where they looked at individuals at risk, or IAR. And so these are what we term high-risk individuals. And they looked at essentially the lesions that were detected on imaging, and they split up the surveillance age in a variety of essentially different categories: under 40, over 40, under 45, over 40, under 50, and over 50. And essentially what you can find by looking at this is that if you screen individuals who are young, meaning under the age of 50, you really find nothing. And this holds true for what they called significant lesions, which are basically pancreatic cancer, high-grade PANN, and IPMN with high-grade dysplasia, or what they called relevant lesions here in the box on the right, which includes lesions that are slightly less, let's call it dysplastic. And so it really seems as if the yield of screening increases above the age of 50, and screening younger individuals likely is not going to give you many findings. I add this slide here because there's been increasing interest in type 3C diabetes, which I know has also been discussed earlier in this discussion, but it does seem like hyperglycemia can be seen up to about 3 years prior to a diagnosis of pancreatic cancer. And frank diabetes happens somewhere on average around 6 to 12 months prior to a diagnosis of pancreatic cancer. We've looked at our high-risk cohort and actually found that high-risk individuals, familial pancreatic cancer patients or those with germline mutations who have an elevated hemoglobin A1C that's in the pre-diabetes range, are more likely to have cysts on their surveillance evaluations. So once we find all of these lesions, what increases risk of progression to frank neoplasm? The Hopkins group has evaluated this and looked at the risk of progression based on a variety of different factors. And this is the risk of neoplastic progression towards cancer. What they found is that radiologic progression correlates highly with neoplastic progression, changes in the cyst or changes in the duct, as well as development of a solid mass. But interestingly, multifocal cysts, and these are frequently found in high-risk individuals, multifocal cysts also predicts neoplastic progression in high-risk individuals. In a subsequent study, the same group also described that the presence of a germline mutation also increases risk, although the p-value was just at 0.05. So anytime we're talking about screening for any cancer, we have to take into account issues around lead and lag time bias. And I think it's a very important thing for us to consider. But I bring this study up because this was a huge collaborative effort through the CAPS consortium where multiple centers submitted their cases who had gone to surgical resection. And I think it's notable that between all of the centers who contributed data to this study, we were only able to really find 71 high-risk individuals who had undergone surgery. We also included in this analysis 5 individuals who had unresectable pancreatic cancer. And what we found is that of those 71 individuals, 32 of them had pancreatic cancer or an advanced precursor, 19 of whom had frank pancreatic cancer, but we were also sending patients to surgery for main duct IPMN, branch duct IPMN with high-grade dysplasia, and advanced PANN lesions. And this is a Kaplan-Meier curve looking at survival for those individuals who had undergone surgery, and it basically makes common sense that those with low-risk lesions, who probably shouldn't have gone to the OR anyways, had very good survival. Those who had early stage disease had intermediate survival, and those who had advanced unresectable disease had very poor survival. On the left here, we see data on survival and surveillance with screen-detected pancreatic cancers that were also published by the Hopkins group about 2 years ago now. They found that median survival for those who were in surveillance was 5 years, which is an incredible improvement over what we saw Dr. Bahari present in the earlier presentation. And overall 3-year survival for those who had screen-detected cancers was 85% compared to 25% for those who had pancreatic cancers that were detected outside of surveillance. Now, there are certainly issues with lead time bias and detection of earlier cancers here, but I think we would agree that these numbers are at least very impressive and do provide some hope that screening for pancreatic cancer in high-risk individuals may provide mortality benefit. All right, so what are the guidelines? These are NCCN guidelines that were actually just updated in December of 2019, looking at high risk assessment for breast and ovarian cancer. And this iteration actually added pancreatic cancer for the very first time. The NCCN recommendation now is to recommend genetic counseling and germline testing for all individuals with exocrine pancreatic cancer. And when those individuals are not available, largely because they've already deceased, to consider genetic testing of first-degree relatives. And at a minimum, the genes that should be tested for germline mutations include the following list, which I think we've reviewed several times throughout these talks, including mutations in BRCA1 and BRCA2, ATM, PALB2, the Lynch syndrome genes, CDKN2A, STK11, and P53. And there's also a comment that pancreatic cancer risk is also increased in those who are of Ashkenazi Jewish descent, and so germline genetic testing of those who are Ashkenazi Jewish may actually have a higher yield. ASCO also has a provisional statement in terms of evaluating susceptibility to pancreatic cancer, where essentially the recommendation is the same, that all patients who have a diagnosis of pancreatic cancer should have some sort of hereditary syndrome. And you see here in 2.2 that the individual with the pancreatic cancer is usually the most informative person to test, but if that person is not available, an unaffected individual relative can be tested with the understanding that a negative test result is clinically uninformative. Why do we do it? Dr. Bahari also showed this slide earlier. One is that we have targeted therapies that he's already nicely reviewed. But two is so that we can perform cascade testing for family members so that they can undergo surveillance not only for pancreatic cancer, but let's say a BRCA mutation is discovered in the family members can undergo appropriate breast cancer surveillance and risk reducing approaches for the gynecologic malignancies. All right, what about screening for pancreatic cancer? I bring this up here because I think this is a very important point. The U.S. Preventive Services Task Force updated last year, just about 1 year ago, I think to the day, a recommendation against pancreatic cancer screening in the general population. It receives a D recommendation, which is that we should not do it. And the reason for this is that even if we have an absolutely perfect test, and we screen, let's say 10,000 individuals, we will find the very few pancreatic cancers that are present in those individuals. But we will also find many other things in the pancreas and elsewhere. And this false positive rate would likely lead to potential harm, and then the harms of screening in the average risk population would outweigh any potential benefit that the patients might derive. We do, however, when risk of pancreatic cancer is increased, generally felt to be above a lifetime risk of about 5% or so, recommendations for increased risk screening for those who are at high risk of developing pancreatic cancer. These were updated and published right around Halloween of last year, and they're published in Gut. The American College of Gastroenterology also has a clinical guideline for genetic testing and management of hereditary GI cancer syndromes, and also includes a section specifically for pancreatic cancer. So the different groups have subtly different recommendations, and I put here the comparison between NCCN recommendations, ACG recommendations, and CAPS guidance. But essentially the way I think about this is that if you have germline mutations in ATM, BRCA1, BRCA2, PALB2, or the Lynch syndrome genes, and you have a family member that is affected by pancreatic cancer. In general, those individuals are candidates for pancreatic surveillance starting at or around the age of 50, or perhaps a little bit younger if the affected individual was young. I'll bring your attention here to the top right for BRCA1 mutations. The CAPS guidelines are essentially done by a modified Delphi process where the participants all essentially voted on a series of statements, and statements required a certain agreement and consensus to become a consensus statement for the guidelines. BRCA1 actually failed to meet the standard for consensus, and so that's a notable difference between CAPS and the other guidelines that we have. For CDKN2A mutation carriers, surveillance starts somewhere around the age of 40, and you can see some of the specifics here. For Put-Jaeger's patients, surveillance can start in their 30s. And for PRSS1 hereditary pancreatitis patients, surveillance starts about 20 years after the onset of pancreatitis or around the age of 40, whichever one is earlier. And for our familial pancreatic cancer patients, and again, those are individuals who have family members who have two first-degree relatives of each other who have both been affected by pancreatic cancer. And then the individual who you're considering surveillance for is a first-degree relative of one of those individuals. Surveillance typically begins around the age of 50 or 55, or a few years earlier than the affected individual was diagnosed. How do we image? We saw the data earlier from CAPS and others. Endoscopic ultrasound and MRI are both options for surveillance imaging. Follow-up imaging is essentially the same thing. Surveillance in the absence of concerning findings happens every 12 months. We shorten the interval if we have concerning findings. And then based on relatively scant data in the hereditary setting, but the data that we have on fasting blood glucose or hemoglobin A1C changes prior to a diagnosis of pancreatic cancer, there was an addition of a recommendation for fasting blood glucose testing and or hemoglobin A1C testing in conjunction with your surveillance imaging of the pancreas. The idea behind this is that these are biomarkers that we already have that are part of routine clinical care by the primary care physician, and so why not incorporate a biomarker that we already have into our algorithm. The targets for screening are resectable cancer that's combined to the pancreas with negative margins. Obviously, finding a widely metastatic pancreatic cancer is not the goal of screening or surveillance. PANN3 lesions, so advanced PANN or IPMN with high-grade dysplasia, are also targets of screening. And then new to the most recent update is neuroendocrine tumors that are over 10 millimeters in size. So to summarize, there are several genetic syndromes that contribute to the risk of pancreatic cancer. We can clearly detect precancerous lesions before the development of pancreatic cancer. I feel that genetic counseling and testing is an important part of pancreatic cancer surveillance, prevention, and management. And surveillance of high-risk individuals can be considered in high-volume centers, but we really do require more work to understand the impact of surveillance. Thank you very much.
Thank you, Aimee. And thank you, Nathan, again, for two fabulous talks. We do have about 10 minutes left for questions, and we have one in the chat box, and I have a couple. So I think for this question will be to Nathan. It's been asked about, what is your opinion about the current state of single beam radiation therapy for pancreatic cancer? Particularly a lot of advanced endoscopists at various centers, including mine, will place fiducials for SBRT. What is your assessment?
So I would think it depends upon the area that we're using it. In resectable cancers is postoperative therapy, maybe for close margins, there's some data, but in prior to surgery, I don't think there's good data for it. In the borderline setting is very controversial. Where it's a little bit better is in this, in the locally advanced setting, either prior to surgery in those patients who can't be resected. And it does offer, I think, some local control, which is important if you're going to be alive for a while because it leads to pain and anorexia. So what's lacking is a true randomized study saying that it improves overall survival. But I think something that improves progression-free survival in the locally advanced setting and local progression-free survival is a good idea.
Thank you. Aimee, I believe you run a high-risk clinic then, and you probably see a lot of patients who come to you. I'm sure they have a lot of anxiety, a lot of questions. One of the common questions I get from patients, and I'm curious what your approach or answer is, they often will say, well, what can I do with my lifestyle, or what can I change? I can't change my genes, but what can I do now in terms of how I live that can mitigate any risk? What do you tell them?
So we have little data on this, and less in the hereditary setting. I think there are some, a few studies. We've published one looking at adherence to certain dietary recommendations and pancreatic cancer risk. And it's really essentially common sense recommendations, which are largely eat more fruits and vegetables, don't smoke, don't drink, and a diet that includes less red or processed meats along the way. We do have clear data that tobacco smoke exposure in the hereditary setting is bad. Genes aren't everything. The same Hopkins studies that looked at the risk of pancreatic cancer by number of affected individuals also looked at risk of pancreatic cancer in those who had an affected first-degree relative by smoking status. And smokers, even in the background of this family history, had 3 times higher risk of developing pancreatic cancer, which tells us that the genes aren't everything. So you can't say, you know, I have a BRCA mutation, I'm just going to smoke, and you know that's what it is. Even when there's a germline mutation or a family history of pancreatic cancer, decreasing tobacco exposure does decrease risk of pancreatic cancer.
So definitely don't smoke. Great. A question for both of you. Aimee showed several slides about some of the screening studies kind of finding incidental neuroendocrine tumors. And then also in one of her final slides talked about how it's a consensus sense that neuroendocrine tumors greater than a centimeter is considered a target. What do we know about the presence of neuroendocrine tumors when discovered when we're looking for PDACs? Is there any common biology that would link the two, or are these really just incidental findings, and if we find them, we just think of them as independent and treat them accordingly and call it a win? Aimee, and then Nathan.
You know, I think in our cohort, we do have several individuals who have small neuroendocrine tumors, and I don't know that we have clear data that we're finding those in increased prevalence over, you know, the general population. We're just looking in people's pancreas more often, and so we are going to find a lot of these indolent lesions. Our experience is that we haven't had any that have progressed to surgical resection, but our cohort is, you know, relatively young since I've been at Mount Sinai, so it's only about 8 years old right now, and so we don't have you know, decades-long experience within our screening program.
Great. Any comment, Nathan, on that?
I'd say that we've found a number, and I think probably an equal number. I'll echo Aimee. I don't know that there's a true connection between the two, but I can't disprove it either. But we've seen a probably an equal number in patients who have trauma scans or something, and they find a small neuroendocrine tumor, as we will in some of the early stuff that Dr. Brand and the group here at Pittsburgh is doing. So I'll just echo what Aimee says.
I would say in our study where we did the germline sequencing for individuals who had undergone pancreatic cancer resections, we did find neuroendocrine tumors in BRCA mutation carriers, but the sample size was really quite small, and so I don't think we can draw any conclusions there.
Great. Nathan, I may have missed this in your initial slides, but in general, what percentage of patients now with sporadic pancreatic cancer are eligible for some type of targeted therapy or immunotherapy, and is that number changing over time? Do you think it's increasing?
It is slowly increasing, but the answer to the first part is probably about those people, the majority of people who have KRAS wild type, which is about 8 to 10%. And we'll pick up another 1% or so of people who are mismatch repair deficient. And I know that we're making a big deal of these 1%, but it's very, if you take a look at lung cancer, right, where they've done a grade of this, small number of ALKs, a small number of ROSs, a greater number of EGFRs, it adds up to a significant number of patients in the end. And the treatment is significantly better for these directed therapies. It's about 10%.
Okay, great. One final question, because it's at the top of the hour then. What is your approach to surveillance for IPMNs after resection? Aimee and then Nathan.
So I'll take it from, in the hereditary setting, we're essentially finding an IPMN typically with concern for high-grade dysplasia. Let's say there's a nodule or something else in the lesion, and we recommend surgery. One is, I think, to comment on what the surgical approach could be, because one could consider a total pancreatectomy or a Whipple or a distal pancreatectomy. We have taken the approach of targeting the lesion of concern and typically leaving a remnant pancreas. And so if the lesion is in the tail of the pancreas, we'll proceed with a distal pancreatectomy. But you're right, that often does leave behind small sub-centimeter IPMNs. And as soon as the patient has recovered from their surgery, we continue surveillance with the same protocols that we were using before surgery.
It's still evolving, I think, within the surgical world that I see in our weekly meetings. And it's usually a combination of EUS and MRIs at an interval depending upon, look every few, maybe 6 months and see if anything changes and extend it from there.
Great. Well, I want to thank you again both for taking your time for providing 2 fabulous talks. And I want to thank the audience for participating. Please, we hope to see you next week at our next series of talks. And thank you and have a nice evening.
And thank everybody for joining.
Thank you.
Thank you.